patient had already been accepted for surgery. He had a discussion with his physician, with his cardiologist, because he had seen the patient in the internet that this disease, left main disease, can be treated with PCI as well. So his cardiologist referred him to our center, not with a question whether left main disease is severe or not, but the question whether this patient could be treated with PCI. So we reviewed left main PCI, yeah. That's why the patient was referred to our center with this question. So we reviewed his images from the diagnostic angio. We all agreed that this left main stenosis is ambiguous, moderate, not straightforward, significant disease. We recalled previous similar cases with similar appearances with this kind of irregularity or haziness there at this acute bend. And I can recall several cases where I've done IVUS in those lesions, and I can remember only one patient who had significant disease with similar angiographic appearance in the left main. So the patient was brought to the cath lab. We decided to bring the patient back to the cath lab and have an IVUS imaging with a view to proceed to PCI if the left main didn't have significant disease. That's why we didn't consider any non-invasive tests such as the CT. So JL35 guide catheter, these are the images from the second time I brought the patient to the cath lab. This is the Volcano, the Philips Eagle Eye IVUS. The wire, as you may see here, was brought to the circumflex artery. I didn't cross the tight lesion of the circumflex with the IVUS, so slow manual pullback. It will take some time, I'm sorry. It's a very slow manual pullback. It's a large circumflex artery, as you see. This is the segment of the circumflex proximal to the tight circumflex stenosis. Some plaque without significant stenosis to the proximal circ. We're getting there slowly. Some more plaque. LAD, distal left main. And this is the area of the bend there, and the ostium of the left main. So we reviewed all frames, all images. This is the worst we can get. There is some, I don't know whether you can call it the superior part of the image. Is it plaque? Is it tissue enfolding? Whatever this is, there is no significant stenosis. A huge lumen of the left main, as you see, 18.3 square millimeters. So, based on these findings, we proceeded to PCI. We put a large stent, 4.0 stent, in the dominant circumflex artery. And then we proceeded to PCI to the diagonal. It was quite difficult to cross, for some reason, this diagonal lesion with a wire. And we eventually deployed a thin strut 2.5 by 16 millimeters stent. The patient is clinically well and asymptomatic 1 year after the procedure. Thank you very much.
2 points. First, in this study that you did, probably you were suspicious about the problem. I'm sure that you gave a lot of nitro. And the second angiogram, it looked that was much broader, that suspicious point.
Yeah, I always give some nitro before the...
It is important.
Yeah.
Especially in this case.
Yes, this patient had...
Dr. Pattakos, our second cardiac surgeon, joined the panel as well. Grigoris, you saw the picture, and the patient was just outside your office.
Yeah. So I think a lot of times, as a surgeon as well, it causes us dilemmas. This case also had a circumflex lesion, but we get a lot of patients referred to us who have an ostial left main, and sometimes you wonder if there's something anatomic about the ostium and the takeoff. And we see it when we perform an aortotomy and we're going to perform AVR and CABG, and you can see with your eyes the ostium of the left main. It really causes us a dilemma when there's no other coronary atherosclerosis and you have an ostial left main. Now, that's not exactly this case, and I think what Dr. Aznaouridis showed us was very nice with the IVUS. But we have to be very careful with these lesions, and it makes our lives as cardiac surgeons easier when they're referred to us with IVUS imaging or with FFR or with something more, so that we know that we're not going to overtreat people. The last thing we want to do is put bypass grafts on a patient that doesn't need them. So your point is well taken.
Okay, Professor Gaglioumi, before giving you the speech, I was just about to say that most likely me and you are the older in the room, and I'm sure that we had cases before the advantages of intracoronary imaging like this that had been sent for surgery before their IVUS era. So the only criteria we had at the time was the drop in the blood pressure. And if there's no drop, then it's okay. But in this case, I'm sure that patients back in the 90s or so, they were sent to surgery.
Okay. We were listening that for surgeons and also for us is absolutely crucial to get an idea about the anatomy. And Tom was spending words about the value of a CT, especially in this case. You have a tomographic view. You might have extrinsic compression of the left main. You can easily decide when you have this tomographic view. And also in favor of CT is in case you might have exactly the projection to work with and eventually some direction also in terms of selection of guiding catheter if you decided to go, and the precise measurements about the left main that was very, very big, sometimes 6. So I think that is a good point. While when you are doing imaging, it is absolutely pivotal the position of the guiding catheter. Because according to the position of the guiding catheter, you can change the geometry in this angulated lesion. And there are beautiful figures published by José de la Torre explaining which one should be selected in this case as the best option, not to go too much higher, but not to go too much lower, like it was in the first angio. So crucial to get this precise information for deciding appropriately.
Yeah, thank you. I think we can proceed to the second case.